It is my distinct great good pleasure to introduce my longtime friend and colleague, Rob DeRubeis. Rob is the Samuel H. Preston Term Professor of Social Sciences at the University of Pennsylvania. I'm going to give you a little bit of background. I hit the University of Minnesota in '77 as an accidental academic. I had no good idea I was going to be a researcher and no good plan for doing that. I fell into a job that I certainly didn't deserve. And that first semester I was there, Rob approached me. He was a graduate student at the time, third year on his internship, and suggested we work together. We did. That first year, we put together a grant. Senior colleague said it was a silly thing to do. I should get tenure first and then do the kind of treatment outcome studies we wanted to do. But we went ahead anyway. Rob had the site, had the therapists, and we did, actually, I think, a very nice study. Really well-done study. I think that suggested that cognitive therapy was as efficacious as medications and had an enduring effect that medications didn't have. With another year or two, Rob was doing the first of the adherence process trials that separated cognitive therapy from medications, served as the basis for the work we did for the collaborative on separating different kinds of interventions. He then went on to educate me about the way that you could take a look at processes, how treatments worked, how mechanisms worked as well. We did, in our Minnesota trial, he did the really elegant work that indicated that despite the fact we got common change in cognition in pharmacotherapy and psychotherapy, it was the cognitive change that drove change in depression in cognitive therapy and the change in depression that drove cognitive change in pharmacotherapy. He really pulled apart the distinction there. He went on, got a job at University of Pennsylvania, which I considered at the time, it's where I came from, and I considered it not as a graduate student, but just as a floatsman jetsam. He went on, got a academic position at the University of Pennsylvania, which I thought was absolutely remarkable. He's been responsible for two people getting tenure, both himself and me, largely drove our earlier interactions. We've subsequently worked together over the last, 35, 40 years. I think his 2005 comparison of medication, placebo-controlled comparison of cognitive therapy to medications is the single best outcome trial in the depression literature, and I think most of the rest of the field agrees. It's been most highly cited, and it established cognitive therapy as being every bit as efficacious as medications in the treatment of severe depression, despite what the collaborative and the APA, American Psychiatric Criterion say. He's now gone on. He's done a number of other really interesting things which you may or may not hear about today, sudden gains, identifying the way in which compensatory skills develop into long-term change and underlying risk factors. He's going to talk today, I think, about moderation, and he's done some really, truly amazing things with respect to how it is that you identify the best treatment for a given individual. It's going to revolutionize the field, and I stop here and give you my longtime friend and longtime colleague, Rob DeRubeis, and I will just say, anybody who's getting started in the field, choose your friends well because they will carry you the rest of your career.
Well, why don't we get started? As soon as I figure this out, yep. Okay, so these are the kinds of things that I'm going to be talking about today. Going to be talking about work on estimates of effectiveness and relative effectiveness of treatments mostly for major depressive disorder, but now we're branching into other kinds of areas, mostly with other people's data sets, as you'll see. We've at many points re-examined assumptions about the effects of treatments. So there are things around, like Steve mentioned, the assumption that severe depression needs medications. That's just one example where we've tried to ask the question, how would you know? And we've then sometimes developed methods that could get us closer to knowing, or so we think or hope. And then we also have developed and implemented tools to identify mechanisms of treatment and to promote the personalization of treatments, which is our big focus now, although we continue to be quite interested in questions of mechanism. Okay, the paper back in the 50s, Lee Cronbach wrote about the two disciplines of scientific psychology and talked about how each has merits, but neither of these approaches is going to tell us everything. We can do experiments, we can do observations, observational studies which trade on individual differences, whereas experiments, of course, treat individual differences as noise. But then, of course, we can integrate experimental and observational methods, and we're going to be talking quite a bit about that today, moderation and mediation of main effects. I'm also going to show you one simulation that we've done. We've done a few. We can simulate common scenarios to illustrate challenges to an empirical clinical science, and that's, at this point, vague and opaque. I hope to make it clear in a few minutes. All right, so let's start with a simple question, a main effect question. What's the comparative efficacy of antidepressant medications versus cognitive behavior therapy for patients with moderate to severe depression? Well, there was a study, Steve referenced it, the collaborative study, that told the world that medications, lower is better here. This is a post-treatment score in Hamilton. And the red is the medicines, that medications are better for people whose intake scores are high in the Hamilton. Pure and simple. Cognitive therapy just didn't measure up. You might note how many patients contributed to this finding, 53 total. And we thought that probably wasn't enough to base a clinical science or a healthcare system policy on. And so what we did was we looked around, and it turned out that there were studies that hadn't focused on severe depression, these folks, but they had them in their studies. And so we gathered the data from these studies and put them together and published that paper in 1999. We were allowed to call that kind of work at that time mega-analysis, which was a little weird, but also kind of cool. Well, now you have to call it an individual patient data something or other. So anyway, so this was a paper we published, and I'm just putting this up here. And then this is the study that Steve mentioned, the 2005 study, which wasn't in this paper. But nice thing about mega-analyses, or whatever they call them, is that you can always add in newer, fresher data. So this is actually not from the 99 paper, but from adding in these 180 subjects from the study that Steve and I and colleagues did. So now with this many subjects, you can see that, yes, the medications are better than cognitive therapy. 0.2 of a point is the estimate, and of course, much of that coming from here. So, all right, fine. Let's look at one of the one study, the last study of those, and I guess I already put a circle around there. And what you see is that in our particular study, again, very similar outcomes. Cognitive therapy and medications, certainly not significant, and suggesting that you can do basically as well in the short run with cognitive therapy. But of course, the short run isn't all there is to treatment of depression. And so what we were interested in was the sustained response over a 16-month period, including the acute phase. And what you see is that if those patients who had medications for the first 4 months, those are the ones you saw on the previous slide, if they had their medications taken away, if you take the arc of the 16 months, 1 in 7 of them responded and sustained it. If they stayed on their meds, that was better. 30% got better and stayed better. If they got cognitive therapy and then stopped getting cognitive therapy after 4 months, better yet. So again, one study doesn't tell the story, but it begins to, we want to ask questions about that. One of the questions that we want to ask is, and this just sets up the thing. So this is the other way of looking at the data. This is everyone's starting at 100%. So now you can see, we're going to focus on this group, 31% of them relapsed. So some people did relapse, okay? Most did not. But we want to ask the question, what accounts for relapse prevention in CBT, or you could flip it around, what accounts for the fact that the effect goes away for some people? We developed 2 measures that we thought might be useful here, and I won't go into those in detail. This is published work, but basically we consider this level of CBT skill derived from 2 indexes. And this just shows you, this is kind of a meaningless abscissa because it's a standardized score of 2 measures. But just to show you that the level of CBT skill varied substantially at the end of therapy from the worst to the best. Of course, we don't know. I mean, I could tell you how good these people are, but anyway, it varied. So why do I show that slide? Good question. Because when we split those people into those who continued to do well, that'd be the sustained responders, and those who relapsed, keeping in mind that all of these people were doing just fine at the end of treatment, symptomatically, but we had measures that we thought might predict who would not hold on and who would hold on to their gains, and sure enough, a very big effect here. The sustained responders, much more represented. You can see there's only one poor person who seemed to have gotten the skills reasonably well, not as well as these people, but who relapsed nonetheless. And the rest are clustered around here. And of course, you can gain the skills. A few people did. I'm sorry, you cannot gain the skills by our measures and not relapse. All right. So we're beginning to get into variation. Talked about main effects. We talked about some variation there. And there's another kind of variation that Tony Tang and I became interested in when he came to do graduate work with me. It was in the course of symptom improvement. But Tony came to me with the question, if basically in depression trials you see that the symptoms kind of go down in a seemingly steady way, but is that how it works? Is that what characterizes change over time in these treatments, or in particular in cognitive therapy? What I'm going to tell you is this looks reasonably smooth, but not as smooth as if you use lots and lots of patients. That's an aggregate of only 3 patients, okay? So you figure, wow, if it's that smooth, it must be that each of those patients is probably moving along more or less like that. Well, not at all. These are the 3 patients. This is a patient who sort of had the first 3 sessions, not so much going on. All of a sudden, a really big change, a really big drop in the Beck depression inventory, and that was maintained, and at the end, even a bit better. Here's a patient. Again, nothing much going on in the beginning. Now for about 5 sessions, big gain there, and certainly didn't lose that gain. And then the third person who happened to contribute to this, that first slide, is someone who had a nice thing going on here, but it was too early to call it a sudden gain. Anyway, what you see at the gain here. The reason you're seeing the 2 points marked is that we were then able to inquire about what was going on in this session, and in particular in this session, that might help us understand why this happened. So this is a session where the person's feeling just as poorly as in this one, and we don't see a gain, but why is it happening here? Well, first, before I tell you that, just want to say that it turns out this work's been replicated in various ways. It turns out it does matter, or it seems to matter. This compares patients, all of whom got better, but these patients got better in cognitive therapy without the benefit of the sudden gain. These patients were benefited from a sudden gain. But notice that they're on the Beck depression inventory, they're doing almost exactly the same on average at the end of treatment. However, you look 6 months on, and the patients with the sudden gain are not only hanging on to those gains, but are really doing even much better. Here it is, show you the data here. That effect wasn't there again at 12 months, but it reemerged at 18. So it's just one study, but it gives you an idea of what you can do when investigating these kinds of things. Where we see sudden gains as a tool that allows you to both inquire about whether there are certain patterns of change or courses of change that are more beneficial, but also whether things that are going on in the previous session can tell you something. So this is, remember I told you there's we call it the pre-gain session, very clever title. Pre-gain session is the one where the person's still doing well, poorly, and doing poorly again when they show up the next time. This is the one they're doing poorly when they fill out the Beck depression inventory. They have the session, but the next session they come in, they're doing quite a bit better. What you see here is we had another measure that we developed that was taken from rating audio tapes. And these are instances in which the patient is talking about changing his or her mind, reconsidering things, taking a different perspective, cognitive changes. And what you can see is there wasn't much of that going on, and then there wasn't much symptom change going on after that. Quite a bit of it going on average, quite a bit of symptom change after that. So here's a question. Is a treatment that's effective on average equally effective for all? Now, I had the privilege of being at Minnesota when Paul Meehl was quite active, and when Paul Meehl was active, he was active. So I read a lot of his stuff and took a course from him and so on, so a lot of things stick in my mind. And one of my favorite quotes from him, it's kind of an odd one, is the null hypothesis is quasi-always false, okay? The idea there being that if you're asking, is this different from that, the answer is always yes. The question is, does it matter? Does it, is it important, and so on. But so, of course, the answer to that is no. It can't be equally effective for all, but it's, I think, a little bit more interesting than that. So this is a paper that generated quite a lot of press, took threats on my life and things like that. This was a paper we published back in 2010 in JAMA, and it asked the question, if you're comparing medications to placebo, does it matter where a patient starts, how bad off they are in terms of symptomatology? Very simple question. You can ask much more complex ones than that, than just about symptom severity, but this is what we did. So we got together the entire set of studies, which would be 6 that were relevant to this question, and we did what was now not allowed to be called a mega-analysis or meta-regret, but anyway, individual patient data analysis. And what this shows is these are very high Hamilton scores, from 25 up to 39. And each of these discs represents a set of patients from one trial or another of the 6. The dark circles represent, the dark discs represent those who are in medication condition. Here, more is better, so more change is better. And you'll notice that the dark discs are hovering well above the empty discs, and that's also, in a way, modeled by the fact that the red line is higher than the blue line. So there it is. The medications work better than placebo, and we kind of knew that, or we did know that. What was known but not talked about was this part of the curve, which is, and this is where, by the way, most patients who come to any clinic, even a psychiatric clinic, but certainly to their primary care doc, these are the patients who get the medications for the most part. What you're seeing here is the white discs and the black discs are very much mingled together. And if you take the model difference, I would ignore, I think, the little difference down there. It wasn't significant. But the point is, down in this range, you get really little or no difference between drug and placebo. And again, this is in the range where most people are coming into the clinic. Okay, so now we're going to shift gears a little bit, and we're going to talk about the heterogeneity of treatment effects, although that was, in a way, an example of it. So the frame that we put to this is that within a population, the impact of a treatment is a function of 3 things. The impact of a treatment. There could be a 4th thing, which would be outside events, life events and so on, but this is the impact of a treatment. It's connected to 3 things. The potency of the treatment, that is how good it is in some general sense. The patient's characteristics, in other words, how much they're going to improve with no treatment or with any treatment. And then there's the most interesting, the one that we spent most of our time exploring and trying to sort out, the degree of match or mismatch between the patient's characteristics and the features of the treatment that might provide change. Okay, and then when we talk about the patient's features, we can talk about prediction from patient characteristics in 2 ways. One of them, again, is the likelihood that any treatment will produce benefit. That would be prognostic characteristics. And then there's the differential benefit expected from different treatments. We call these prescriptive characteristics. They're also referred to as moderators. All right, so why should we model heterogeneity? Well, a model can inform treatment selection. In other words, if you have a good model, and someday we'll be using these in clinics, they can inform treatment selection under these 2 conditions, either of these. If you're asking yourself as a clinician, which treatment should this patient get for this disorder? We have 2 or 3 or more treatments. You can use the models to suggest which of the 2 treatments is likely to be the better one for that patient. So, for example, antidepressant medications versus cognitive therapy. We're going to look at that in a couple of minutes. We have a study of that. We're working on many projects, one of which is prolonged exposure versus cognitive processing therapy. Is it that if a patient's going to get better on one, they're likely to get better on the other? Well, no, at least in the meal sense, no. But we're also finding that it's not just trivial. There are these differences that would be helpful in directing patients to the better treatment. And then there's a second case, and this is an important one as well, I think. We often have a situation where we could decide to put someone into a really intensive or expensive treatment, Or, particularly in a stepped care model, we might decide that it's just fine to get them started on something less intensive, like lifestyle change or e-therapy or what have you. So there are many situations that are like this. We have data that I might get to antidepressant medications versus the combination. So we've done some treatment selection work with that. And then I'm going to show you one treatment as usual versus CBT. We'll be sure to get to that. Our general modeling approach can be used to reveal phenomena that are hidden in data from outcome or process studies. In other words, the main effects don't tell you any of the kinds of things that we're about to talk about. So one of the things that we see and that we worry quite a bit about is that two treatments can evidence surprisingly small differences in outcome on average. And we're going to ask if there might be some things hiding there. And also this relates to therapy process mechanism work. Therapy processes or mechanisms might evidence surprisingly weak effects. Now, when we do all the work of gathering all these kinds of data that you do for treatment studies, and we get these surprises of small effects, what can account for that? Well, there are a variety of possibilities. I'll list them. One is that the treatment wasn't delivered in a potent kind of way. That's a possibility always. Could be that there's an unreliable measurement of a process, if that's what we're interested, or poor operationalization of outcomes. So we're still right, We're still, our process is still the right one, or our treatment is still the right one, but something just didn't quite work in that study. Those are all possible. Or, of course, it's possible that our intuition is wrong about the process of the treatment. The thing just wasn't that good. Or our intuition, it might be correct, but only for patients who could benefit from the strong treatment or the strong process. So the insight here is that our intuitions about treatments and processes aren't meant to account for patients who are unlikely to need a strong treatment. We're going to call these, just for convenience, spontaneous remitters. And they're also not going to account for patients who are unlikely to benefit from any of our current treatments. We're going to call these intractable patients, just because we can't come up with a better word yet. All right, so what happens when a strong treatment is compared with a weak one in different contexts? And I'll tell you what I mean by contexts. And this is a simulation study that we conducted. Lois Gelfand and Jay Fournier were the main ones that were my collaborators on this study. Okay, so we're going to set up a hypothetical. We're going to set up a simulation in which there's a strong treatment which on average yields 55 points change. The strength of the treatment is meant to, and actually does, under ideal conditions, yield 55 points of change. Let's not worry about change in what. But there's the strength of that treatment does vary. Let's say you have some therapists who are a bit better than others, and so there is some variability even in the delivery. And then you have a weak treatment that's weak by definition, by stipulation. 45 points is its average, but it also varies. Some of the practitioners are a little bit better than others, let's say, if it's a case of several therapists. So therefore, what you have, what I've set up, is a standardized mean difference of 10, and with the pooled standard deviation would be the same as the standard deviation of 15. So if you ran a study where you knew this to be true, you would expect a 0.67 SMD or D-type effect size. That's the way it should work, right? Because one thing's better than the other by that much. So what we did, we simulated studies that tested this strong versus weak situation with different distributions of patient response patterns, which we'll get to. And the simulations involved 1,000 studies in each of the conditions that I'm going to talk about. And what we're imagining is that you're running studies of 60 versus 60, 60 patients versus 60, strong versus weak. So let's meet the patients. This is our friend, the spontaneous remitter. This is someone, if you give them a strength of treatment 0, will get 100% better, okay? They will also get 100% better if you give them the best treatment there is. So this is going back to the idea. You're not going to be able to tell the difference between a strong and weak treatment on the basis of this patient. Likewise, the intractable patient, if they don't get any treatment, they'll get 0% better, but you give them the best treatment there is or that you have, and they will also get 0% better. Now, those are obviously extremes. We don't have them mixed into the models very much, but there's all these folks in between. There's the challenging patient. We all recognize the patient who, if you don't give them a very good treatment, they're not going to get much better. But if the stronger the treatment you give them, the better the treatment you get them, the more they're going to benefit. There's the easy patient, going to get better without any help at all. And if you give them a bit of help up to a certain point, they're going to get about as good as they can get, and diminishing returns after that. And then there's our favorite patient, the pliant patient. This is the patient that's going to tell us exactly how strong our treatment is. If they don't get anything, they're not going to get any better. If they get the best, they're going to get all the way better, and everything in between. All right, so this is just showing the two distributions of the strength of treatment. So this represents the frequency distribution in these simulations of the strong treatment is the blue, and you see that the mean is about 55 there. But you notice there's also some overlap. But anyway, this is the result you would get. This tells you, or gives you a clue about the result you would get if all the patients were pliant. Well, that's not going to happen. You're not going to have a study in which that happens. You're probably not, in fact, almost certainly not going to have a study in which this happens, in which the pliant patients represent the majority, easy and challenging a bit, quite a bit less, and intractable on the side, but I'm going to model that. And then we have a distribution that depression researchers, I think, would recognize, a skewed distribution. Maybe there should be a little bit of representation down here, but in depression, we know that a certain amount of patients get better no matter what you do, even if you don't do anything. Other patients will get better on pretty much any treatment, but then there are some patients who will really show you how strong your treatment is, and then there's some patients who will really test you. Okay, but this is the distribution we call a skewed distribution. Okay, so we aggregated the findings from 1,000 studies in each condition, and in the condition with pliant patients only, this is the ideal, we pretty much recovered the 0.67. You don't, in simulations like this, you're never going to get exactly what you put in because there's randomness built in, but basically that's the finding. That's what you expect. It's stronger than the other one. You should get that big a difference. Okay, well, and that's represented here again. What happens if you do that same simulation with the predominantly pliant patients? Well, now that effect size, same treatments, same strong versus weak goes down to 0.48, and the skewed, it goes down to 0.24. Now, 0.24, when you probably don't get that study published, right? Because, first of all, it's not going to be significant. And you're going to look and you say, oh, well, those treatments are pretty much the same, 0.24, who cares? Okay, well, actually I care, but I'm hoping to get you to care. This represents it in another way, and this is kind of scary. In fact, Arnold Arntz commented after a talk I gave on this that it scared the hell out of him. So be ready for that. I don't know if it'll scare the hell out of you, but it's kind of shocking to me. So this is what would happen if you ran 1,000 studies. With the all-pliant, of course, you'd recover that 10-point difference that you put in. I already told you about that. And a little surprising maybe that but at least in 95% of those studies, you would get a publishable finding. It would be significant. But that's the idealized. That's never, ever, ever going to happen. In the predominantly pliant, you still get a pretty good mean difference. I told you already the SMD is 0.48. Your power is a little iffy, and you're almost never going to get that either. The predominantly pliant, this is not what happens when we recruit patients into studies. In the skewed, I already told you the 0.24. Your mean difference is only this. It's not 10 anymore. 1 out of 12 times that you run that study, you will get a publishable result. Not very good power, and this is sort of the typical distribution that we see, I would say. But even if we're off a bit, you get the point, I hope. Anyway, but that was a simulation. What happens in the actual world that's not in my imagination? Well, This is a study conducted by Lorenzo Loasis in collaboration with myself, Annemieke van Straten, and her colleagues. Annemieke, a Dutch psychologist, had published a study in 2006, randomized trial of treatments for depression provided in Dutch community settings. Big study, should have reasonable power to test for differences, certainly main effects in treatments. Treatment as usual, we're not going to worry about what these things are. Suffice it to say, they were put in there and expected to be weaker than cognitive behavior therapy, okay? The main finding, nada. No substantial or significant differences in outcomes among the treatments. Yikes. Okay, but are there patients who show the expected effect and therefore others who clearly do not? Well, this is an example of one of our multivariable models that we ran, and we do this. We believe these are honest models, not overfitting, et cetera. I don't have time to get into all the ways in which we try to ensure that. But anyway, we constructed a multivariable model so that we could essentially array patients on this patient response patterns dimension that I've been referencing. We didn't use the terms, but it's the concept. And these models are not, they have stuff in them that makes sense. They just do. So what you're seeing here is with the negative numbers, people who are unemployed were not likely to do very well in treatment generally, or predicted not to do likely. People with recurrent MDD, less likely to do than non-recurrent. People with hostility, less likely to do well in treatments. People with sleep complaints, and then people with low on extroversion, also not so likely. So we're arraying patients. So patients can be anywhere along this continuum, and sure enough, if you array this continuum and now you take that in interaction with treatment, you get a highly significant effect. So it really matters. The differences between the treatments differ as a function of the patient's location on this dimension made up of these variables in a multivariable model. So this is to sort of remind you, if you will, or to show you with a picture of the null effect in the full sample, okay? This is just what happened. This is basically what was published in 2006 and published honestly and correctly. This is what happens when you take that multivariable model and you use the Benjamini-Hochberg method to tell you where to make the cut. It is a significant interaction. So in the patients who looked like they were going to do probably okay without the strongest treatment, the best 73%, we call them, look at this. Sure enough, it didn't matter what treatment they got. You take the worst 27%, these are the toughest patients in this sample, toughest by the virtue of the multivariable model. You get 40 and 44% are the people who remained in major depressive disorder status, who got rid of their major depressive disorder status, 65% in cognitive therapy. And highly significant here and significant there. So it really does matter. It really does matter who the patients are, not just what the treatments are. Okay, so I want to introduce you to another way to look at who patients are. Much of this is familiar to you. So this is just, this shows you the percent improvement that you might see. These are arbitrary. I could have put it up to 100. But at any rate, spontaneous remitter is somebody who's going to do about the same on placebo, on treatment A, whatever that is, and treatment B, whatever that is. These are two strong treatments, by the way. Patient number 2 needs a strong treatment. They're a pliant patient, if you will. They're relatively pliant. So not going to do very much with a placebo or weak treatment. But you give them a good treatment, whichever it is, they're going to do fine. And then I've already talked about the intractable patients. These could be down at 0 if we wanted, but the point is they're all very low. Doesn't matter. You can give them a strong treatment. It's not going to help them that much. Well, these are the people that we've been focusing on the most. And these are patients who need a strong treatment, but they need the right one. This patient needs treatment A. This patient needs treatment B. How do you figure out who these patients are? So we're going to return to the study that we published the main findings in 2005. And we're going to just show you that the response rates, and now this is met response criteria, were essentially identical between medications and cognitive behavior therapy, so 58%. So the others either dropped out of treatment or didn't respond. Okay, so again, got the same effect from the two treatments. And so the question is this effect moderated, or can we find moderators? Well, the standard way of doing this kind of work, and it was standard for us as recently as about 6 or 7 years ago, was to identify a big variable, or one at a time variables anyway, but a big variable moderator, and then sort on it. And sure enough, we had a pretty big variable. If patients had comorbid personality disorder and they were randomly assigned to medications, more is better in this slide, they were more likely to respond to the medications than to the cognitive therapy. If they didn't have comorbid personality disorder, they were more likely to respond to the cognitive therapy than the medications. So there you go. But what if there are other moderators? Well, there were. We had 4 other ones: marital status, employment status, number of prior medication treatments, severity of recent stressful lifestyle events. And so we don't do number 1 anymore. Our research approach is to identify multiple moderators if they exist in a data set and to generate and test a predictive model based on them. So the question is, how can an actuarial approach improve treatment selection? So I was going back and reading Paul Meehl's book published in 1954, Actuarial versus Clinical Prediction, and he seemed to be asking for this kind of thing. And so I'm, 70 years later, something like that. Somebody in the audience can do the math. Anyway, we think that that's what we're after, is actuarial prediction that can be, we hope, useful. So we came up with this handle, the Personalized Advantage Index. We're working on this stuff for a couple of years, and people were looking at us funny when we talk about it, and we're trying everything to get things going. And so anyway, coincidence or not, it's when we came up with this moniker that things took off a bit. So Personalized Advantage Index, PAI, the features are that it handles multiple interactions. It quantifies the expected difference between interventions for each individual. And in so doing, it identifies patients for whom the expected difference is quite large, as well in one direction or the other, right? It can be favors one treatment by a lot, the other treatment by a lot, or favors a treatment by very little. And so that's the last point. It can also identify patients for whom the expected difference is quite small. So I'm not going to get into the modeling of this. I'm happy, and so are my guys here who do all this work. Suffice it to say that our first time out, we used a standard multivariate modeling approach with the interacting covariates. And the dependent variable was post-treatment Hamilton Depression Score. We're trying to predict to that. And the independent variables are prognostic and prescriptive variables. And so I'm just going to show you the outcome. This is published work. So this is what happens. And we would say, more or less, this is true, that if the patients, instead of being a randomized period, if they've been randomized to their optimal treatment as dictated by the model, their Hamilton Depression Score would have been a 9.2. If they'd been randomized to their non-optimal one, according to the model, they would have ended up with 11. Now, that's not a bad difference there, but we wouldn't expect that difference to be huge, because remember, many of the patients are predicted to do about the same. So if we take the 60% of patients with, I wouldn't call them extreme scores, but more with bigger scores, randomized to optimal, 8.5, randomized non-optimal, 12.1. That's a bigger difference than you get in most any placebo-controlled trial, placebo versus drug. So these things can matter, and we've actually refined our methods now in ways that don't overfit any more than this, and we hope don't overfit at all. And actually that difference is when we do things with the better methods, that difference gets a bit bigger. Now, can predictions from a multivariate model generalize to another population? This is a big question. So, okay, you can do protections within a data set, and we think we do protections that are quite good. But the big test is whether you can take a model, apply it somewhere else, and see if it works there as well. And I want to go through this a bit quickly, but the question that the data set that this is used with is the question of can we use the PAI approach to identify patients who would most benefit from the addition of medications, of cognitive therapy to medications. And what you see is the average effect. There's a 10% bump when you add cognitive therapy to the medications. This is a paper Stephen and myself and colleagues published last year. A 10% bump, it increases from 60, rounding, it increases from 66 to 75%. So could be that each patient's odds go up a little. You get more, more treatment. You're just more likely to do better. But of course, it might be that some patients' odds go up a lot. Others go up a little, if at all. All right. And so the question is, whose odds are improved? If we go to the matching hypothesis, whose odds are improved by the addition of cognitive therapy? Most guidelines say that the combination treatment is really needed for patients with severe symptoms. Okay, not crazy. But we were interested in whether we could do better than that with a multivariable profile. So what we did, and the point of this part of the talk is to say we built these models in 2 sites. This is Nashville, this is Chicago, and then applied it to the City of Brotherly Love, my site, to see how well it would predict within there what treatment people should get. And we did this 3 times. I didn't need to show you all 3 slides, but you can figure it out that you can do 2-1, 2-1, 2-1. These are the variables that were in the models. So again, these reflect kind of severity, number of deprived episodes, low age of onset, loss of interest, low loss of interest, and so on. So these featured in the various models. And the question was, how did this model do relative to a simple severity index? Well, first of all, highly significant versus non-significant. But this is the story. These are patients who the Hamilton, with low Hamilton scores, and our model says, oh, they'll do fine with the lesser treatment. And sure enough, the difference between between medications and the combination, you basically get no benefit from adding the cognitive therapy with these milder, if you want, cases by virtue of the Hamilton, or good prognostic cases from our multivariable standpoint. If you, but look, big difference there for patients who who both had a high Hamilton and looked really bad on our index, okay? Big difference adding the cognitive therapy to the medications. But what happens when the 2 systems conflict? Well, this is what happens if you have a bad Hamilton, but we say you're just fine. No benefit from the addition. This is what happens if the Hamilton says you're just fine, low Hamilton, but our index says not so good. Huge difference there. So it's just showing the promise of putting information together, and I'd be happy to talk to you about why we think that is. There's a whole set of ideas that we have about that, but maybe they're intuitive to you as well. All right. Now, our mission going forward is to apply ever-evolving PAI methods to uncover moderated effects and the mediation of such effects in existing data sets. And we, I don't know what our last count was. Zach Cohen has been the main guy doing this and directing a lot of this work, and he's very good with outreach as well. And we've got about 20 or so data sets that we are working with for people around the world, States, Canada, Europe mainly, who have results in the can. They have main effects that they've found, and may even have found a moderator or 2, but have not applied these kinds of methods. And it's frankly kind of scary how powerful these methods can be, and I want to see what I mean by scary in a minute. Or I'll explain that more in a minute. So we're also looking for the opportunity and funding to conduct prospective tests of prescriptive models. So that's the scary part. So all of these things that we've done the 2 sites going to the 3rd site, and that gives us some confidence that these things aren't just going to wash away when we transport them. But the real test, and the one that's going to make it so that health systems might even think about implementing these kinds of things, is the one that where we would test these things prospectively and preferably in another site other than the ones where they've been developed. And also, we're very interested in promoting the further development of what's called precision mental health. We didn't make that term up, but that's what it is. We started that with a conference that we put on at Penn last summer, again, Zach's idea to call it the Treatment Selection Idea Lab. And we did that, and we had quite a nice group not quite a nice group, an excellent group of researchers from 8 different countries who were interested in these kinds of things. And we had a wonderful 2 days that actually spilled into a 3rd day by people's own preference. And that 3rd day was a Sunday, and we just kept going. Anyway, great group. We now have plans to do a second one at University College London. Steve Pillings offered to host that. And there's the logo, the Treatment Selection Idea Lab. And also, the MQ has been just fabulous with us. We've gotten a couple of grants from them. It's a British foundation that funded our work, very kind of believes in us, I might say. And we just got a grant to conduct a modeling tournament. Now, this isn't one that we would invite Donald Trump to. It's a different kind of modeling than what he might be interested in. This is a modeling tournament where we're inviting researchers from around the world to compete to see who can make the best set of predictions, where the best means taking the data that we each get. We all get the same data set. The best predictions are those that create the best outcomes, the best aggregate outcomes in a sample that's held out, that no one gets to see until the models are applied. So we're going to be interested to run that tournament, and at the TSIL, that's going to be the focus. One of the focuses is a discussion of the methods people used and so on, and a discussion of how to advance this work. I've been so lucky. I mean, the folks that I've had in my lab over the years, I don't know what to say. But I've already mentioned Zach Cohen, Jack Keefe's current graduate student. Lorenzo's in the audience here and has done amazing work, including one piece that I showed you. Nick Foran came up with the idea, essentially, for the PAI. Jay Fournier, I mean, these Rami Collins here. It just goes on. I mean, these are incredible people, smart people, fun people. And I mentioned Tony and really incredible folks. And then these folks need no introduction. I have the fortune of I have lunch with Tim Beck once a week, and he's always asking me, what did you do this week? And then he tells me what he's been thinking about or writing at age 96, going on 97. Steve's a bit younger, but he's no less active and engaged, and has just been a fabulous friend and colleague. But I've also been so lucky to connect up with European collaborators. So, I mean, we all know what's happening here in the States in regard to clinical trials. They're not happening pretty much, at least none that I would want to do. And so these are the folks who are really carrying the water now in Europe, where they're quite interested in comparative efficacy. And when you have comparative efficacy trial, you can do so many things with it. I've shown you a little bit of what you can do with what we've done with these kinds of trial data so far. But these folks have been great, and it gets me over to Europe, which is great fun as well. Wonderful people. So anyway, that's it, what I have. I don't know if I have a time for a question or so. I'll get that from the organizers, but thanks for your attention. Happy to talk about this stuff to anybody at any time, as with my group.